Hi, everyone. Thank you so much for joining us for this part of our virtual lecture series. We're very happy to have you. Our speaker tonight is Dr. Robert Cotes. He is a professor in the Department of Psychiatry and Behavioral Sciences at Emory University School of Medicine. He is founder and co-director of the Clinical and Research Program for Psychosis at Grady Health Systems. His research focuses on clozapine, cardiometabolic side effects of antipsychotic medication, other pharmacological and psychosocial interventions for people with schizophrenia, and understanding the potential for digital biomarkers in mental health. Finally, he is a 2022 recipient of the NAMI Exemplary Psychiatrist Award and serves as editor-in-chief of Community Mental Health Journal. So welcome, Dr. Robert Cotes.
Thank you so much, Bethany. It's a real honor to be here. I'm so inspired by all of you, and I'm inspired, of course, by your work, Bethany. And I think this is a very well-informed group of people, and I'm not sure how much I'm going to tell you that you don't already know, but we are going to sort of talk a little bit about medication, and in particular, clozapine, and in particular, um, some of the new FDA-approved medication um, called xanomeline trospium chloride, which is also called Cobenfy. And where does all of this fit together in sort of helping people with schizophrenia? All right, next slide, please. So here are my disclosures. Next slide. And here's a little bit of our learning objectives. So first, and I think most importantly, and I think everyone is well aware of this, is that schizophrenia is a highly treatable condition, and antipsychotic medications can help. And we're going to talk a little bit about first generation dopamine receptor blocking agents and second generation dopamine receptor blocking agents. Then the unique place of where clozapine fits in, maybe some updates with the FDA after the advisory committee on clozapine, and we'll also talk a little bit about Cobenfy. All right, next slide. Here's a little bit of an outline. We're going to just do the introduction first. Next slide. And I mean, the first thing I have to say is that people can and do get better. In my, I run a program for people sort of with psychosis across the continuum, starting at the clinical high risk stage to the first episode stage, to also, for people who are taking clozapine. And we've really tried to build a community that supports each other, and really lives and values lived experience. And people can and do get better. And, we uh, kind of take an approach where we expect recovery. All right, next bullet. I have to really say that now in 2025, if someone has a first episode of psychosis, it's so important to connect them to a coordinated specialty care team for early psychosis. And these teams are across the country. They don't hit every part of the country quite yet, but they have a team-based approach with sort of all the things that somebody needs in order to be successful. And sometimes it's much easier to have this coordinated approach than just sort of putting the team together yourself. A big problem in today's healthcare system is the lack of coordination, like getting a psychiatrist to talk to a therapist, to talk to an employment specialist. And really, like, this model helps to build all of that in together. Also in general, about a quarter of people will have some early sort of attenuated symptoms of psychosis that might be a clue that a later episode is coming. And from a public health standpoint, we really try to create interventions that help to reduce the duration of untreated psychosis. Where I work in the Southeast, in Atlanta specifically, the duration of untreated psychosis on average for people coming into the hospital is quite long, and we've really been trying to figure out ways to reduce it. The goal for anybody who has schizophrenia is to have a functional recovery. Schizophrenia itself has a heterogeneous course, meaning, the trajectory of schizophrenia, the outcome, the rates of recovery all look different for different people. Next bullet. There are different symptom clusters, positive symptoms, negative symptoms, cognitive symptoms, which you all are familiar with. And the negative and the cognitive symptoms probably cause more functional impairment than the positive symptoms do. The medications that we have, particularly the dopamine blocking receptors agents, are pretty useful for helping with the positive symptoms, but do less for these other negative and cognitive symptoms, and often other interventions are necessary. All right, next slide. Now we're going to be talking about medication, but it's important to recognize that I often think, like, if medication is the only part of this person's treatment plan, we're doing something seriously wrong and we need to get other interventions involved, other psychosocial interventions like cognitive behavioral therapy um, for psychosis, supported employment, case management, peer support. And I feel like in building a clozapine clinic over the years, really what we've built is a psychosocial rehabilitation, psychosocial, building in really the psychosocial interventions part. So, this is just, again, one part of the treatment plan. Next slide. I always like to talk about the medical model and the recovery model, and really encourage my colleagues that prescribe medication to think about the recovery model. So the medical model is about, when somebody, a patient comes in with symptoms and then they get treatment from some sort of an expert, and that's sort of the key to wellness. The recovery model, I think, puts it a little bit differently. So you can go ahead and advance. Um, it's really starting with the stance of where you are and then figuring out what the goals are. And then really treatment uh, comes into really in a different kind of place. All right, so advance again. The treatment really is coming in to help somebody overcome the barriers for what their goals are. One more advancement. And also, I think that the sort of perception of expertise is different in the recovery model. It's more of a flattened hierarchy approach where everybody's bringing in their expertise together, and we're all learning from each other, and all voices are valued. So I really think about medication as a way of helping people accomplish their goals rather than just ameliorating symptoms. All right, next slide. All right, so we'll talk a little bit about the dopamine receptor blocking agents. I think before Cobenfy, we probably called them antipsychotics, but now there's different kinds of antipsychotics. All right, next slide. So if you look at the APA guidelines for the treatment of patients with schizophrenia, this is sort of what it says about antipsychotic medications. It says that people with schizophrenia are treated with antipsychotic medication, monitored for effectiveness and side effects. And then the next part is important because it says whose symptoms have improved with an antipsychotic continue to be treated with an antipsychotic medication. So this is sort of saying that maintenance antipsychotic medication is what is recommended. And international guidelines may actually differ here. Some would say, after a trial of antipsychotic medication, consider stopping after X number of years. But the APA guidelines really say, continued antipsychotic maintenance treatment. And the reason is that there is certainly for some people a risk if they, stop antipsychotic medication, have a relapse. Sometimes it can be more difficult to treat over time. And sometimes this starting antipsychotics, stopping antipsychotics, which I understand why people would do that, can lead to a more difficult course overall. And really sort of minimizing the number of relapses is probably important. All right, next slide. Yeah, so it's important to kind of get a sense of what to expect from antipsychotics and what not to expect from antipsychotics. They can improve symptoms, particularly positive symptoms, functioning, and quality of life. From an efficacy standpoint, the first generation antipsychotics versus the second generation antipsychotics are roughly equivalent, but they have different side effect profiles. All antipsychotics overall block dopamine receptors, D2 receptors throughout the brain. Um, and then, the atypical antipsychotics have a higher degree of serotonin 2A antagonism than the typical antipsychotics. And that mostly results in less drug-induced movement disorder side effects, things like Parkinsonism in particular. But it's also important to keep in mind that there's this sort of difference between these first and second generations is somewhat arbitrary. Some people would even say that the partial agonists like aripiprazole are third generation antipsychotics. And within each of the antipsychotics, there's a lot of differences in their mechanism and their side effect profile, even sort of outside of the bounds of typical and atypical. All right, next slide. This is just a list of the first generation antipsychotics. And we can go to the next slide. This is the list of the second generation antipsychotics, starting with clozapine, which we're going to come back to, risperidone, olanzapine, quetiapine, and we'll keep going. Next slide. Here's where we start getting into some of the partial agonists like aripiprazole, ziprasidone, paliperidone, cenapine, iloperidone. Next slide. And then some of the newer FDA-approved dopamine receptor blockers are here: lurasidone, brexpiprazole, cariprazine, and lumateperone. And some of their unique properties are displayed there. This is sort of a list of the different types of side effects one can have from antipsychotic medications. And we'll talk a little bit about drug-induced movement disorders, hyperprolactinemia, anticholinergic side effects, sedation, orthostasis, QT prolongation, and weight gain and cardiometabolic side effects. So they can really have a number of side effects, and it's exciting to think about new options that might not have some of these side effects. Next slide. Okay, so I've been very interested in how antipsychotic medications cause weight gain and potentially what to do about that. So it seems like most likely antipsychotic medications affect the satiety point in the brain, sort of like that's the point that tells us that once we've eaten enough, we're full. And there's some dysregulation that in the satiety mechanism in the brain that causes folks who take antipsychotics to eat more and more. And really it's this sort of eating more that results in the weight gain. And when people eat more, it puts people at risk for diabetes, and probably through another pathway. It's likely that antipsychotics can cause elevated cholesterol. But it really, I think, like starting with the increase in the appetite is really like I think how antipsychotics kind of start with this sort of cascade of problems that leads to other health conditions. And typically the more antihistaminic the medication is, like the more H1 blocking the antipsychotic has, something like olanzapine or clozapine, the more typically you see these sort of cardiometabolic problems. And there was a new guideline that was published just this past year that was sort of a metformin consensus guideline. And now people really talk about starting metformin right along with medications like olanzapine and clozapine together. So you start them together instead of waiting until someone gains weight. Maybe you can even start these medications concurrently. Okay, next slide. This is a list of drug-induced movement disorders, tardive dyskinesia, and NMS, which is fairly rare with the atypical antipsychotics, but can occur in somewhat atypical presentations. So, I think one thing that's happening across the mental health space is we're seeing more and more people prescribed antipsychotics for more reasons beyond just schizophrenia. You may see antipsychotics used for people with bipolar disorder, people with major depressive disorder, and there's sort of an increased number of antipsychotics used for a variety of reasons, which makes it important for us to monitor for these side effects, particularly tardive dyskinesia. And the tardive dyskinesia occurs over time, and people are more likely to have tardive dyskinesia as they're taking antipsychotic medications over longer periods of time. And there are good treatments now for tardive dyskinesia. In the old days, people used to refer me folks who had tardive dyskinesia and persistent symptoms of psychosis, and they were really good clozapine candidates. But nowadays, the VMAT2 inhibitors are really quite effective. These are, medications like valbenazine and deutetrabenazine, and I think are really the first line treatments for tardive dyskinesia. So it's an important thing to look for if you or a family member or a loved one is starting to have some abnormal movements or involuntary movements of the mouth or face. It's important to talk to your prescriber right away. Okay, next slide. So, I think we sort of look at medication adherence or medication consistency um, as something that happens frequently. It's something to take a non-judgmental stance with. It's common for people with schizophrenia, and and it may be higher. The rate's higher than it might happen for other people with other conditions. Um, you know, I used to work on an inpatient unit for many years, and I would sometimes see some of the same folks in the outpatient setting. And discontinuation of antipsychotic medications after the inpatient unit is quite common. And here are some of the numbers. About a third discontinue within 30 days, and over half discontinue within 60 days. And in many studies, the most common reason for psychiatric readmission is the lack of adherence. We don't really say compliance. We'd probably use more adherence or medication consistency. Next slide. So, I really like going back to this concept of using medication to help people accomplish what they want to do. Can be a very important way to do it, but everybody has their own model for why to take medication and what kind of what kind of explanatory model helps them to do it. So it's really important to figure out, what is that model for you or your loved one? How does medication help, maybe not just stay out of the hospital, but, stay in school, um, stay connected in relationships, et cetera. And also including the family is really, really important in that. Okay, next slide. So I've listed, some reasons for medication non-adherence. And actually, I think one of the big ones is this last one, the lack of efficacy. Like, antipsychotic medications don't work for everybody for positive symptoms. Maybe 20 to 30% of people are not going to really have much of a response. And in those sort of situations, it's you know I would understand why someone
Hello,
wouldn't
this is
take it all the
Gordon.
time if it's not helping at all. So
Yes, ma'am.
like not taking medication is more than just not believing one is ill or side effects. It's sort of like there's many reasons why someone wouldn't take medicine, and there's many reasons and there's also probably many strategies to help people be more consistent taking medication. All right, next slide. So, I think that long-acting injectable medications can be quite an important tool. Um, Studies demonstrate that people in sort of early psychosis will accept long-acting injectable medications, and it also helps to prevent relapse. There's no reason to wait until someone stops taking medication in order to do it. The APA guidelines now recommend that if someone would prefer to be on an LAI, then it's certainly okay to use one. So we typically offer LAIs to everyone, just sort of as a matter of preference. Sometimes insurance companies might say someone has to be non-adherent in order to get an LAI, but I do think that there could be some bits of pharmacoadvocacy that could be helpful in changing that and really sort of making it more of a preference-based determination. Next slide. This is a list of the current long-acting injectables and their sort of the compounds, and then their formulations. So there's haloperidol, fluphenazine, then there's 3 aripiprazole products, 1 olanzapine product, 4 paliperidone products, and 5 risperidone products. On this slide, I included a compound called TV 44749, which is a subcutaneous form of olanzapine long-acting that's currently being studied right now that looks like it has less risk of PDSS, which has been a big problem for Zyprexa Relprev. It could be a nice tool if it's approved. But I show this slide here, which is courtesy of a colleague, Megan Arrett from the University of Maryland, to say that there's a lot of long-acting injectables on the market now, and it's important that health systems and that patients and everyone all are kind of aware of these and make sure that there's not confusion, because sometimes more options can kind of mean more confusion. It's good to have more options. It's good to have a 2-week option. It's good to have a 6-month option. It's good to have intramuscular injections. It's good to have subcutaneous injections. So overall, I think the numbers are good. This is sort of a roadmap. All right, next slide. So yeah, clozapine. Next slide. Clozapine is a really, really important tool and a really, really important medication, and can really help people get their lives back together. From the APA guidelines, it shows up in 3 places. The first is minimal or no response to 2 trials of an antipsychotic medication. The second is people with schizophrenia or schizoaffective disorder, if the risk of suicide attempts or suicide remains substantial despite other treatments. Clozapine is highly underutilized overall, but particularly for the second reason here. And then the last one is a suggestion rather than a recommendation. And this is for people with schizophrenia who have a risk of aggressive behavior, because it has a unique efficacy there. Next slide. So, in my experience, a lot of times it's the person or their family or their loved ones that actually suggest clozapine. And, I think that if then that can be a very, very powerful tool, as if because it's clozapine is highly underutilized, and sometimes it's because the prescribers don't feel comfortable using it because it has a number of side effects, which we'll talk about. So the response rates for what's so-called treatment-resistant schizophrenia, which is poorly named, and basically that just means that someone has not responded to 2 trials of an antipsychotic medication for an adequate dose or an adequate duration, are like 0% for typical antipsychotics, maybe 7 to 10% for high-dose olanzapine, and 40 to 60% for clozapine, which is the only medication really expected to work after someone has had 2 antipsychotic trials that haven't really worked. But even now we're seeing that maybe that might be fewer than 2. I see people all the time who have tried, 7 antipsychotics or 9 antipsychotics and are finally coming around to clozapine, and that's often far too long of a delay. And when you talk to people about it, like, they often prefer clozapine over the other antipsychotics because it helps them and can help reduce positive symptoms and can really be quite an important recovery tool. All right, next slide. So, if you estimate that, depending on the study, but between 20 to 30% of people with schizophrenia don't respond to um, dopamine receptor blocking agents. And right now, that's between 20 to 30%, let's say 23%. So if you follow people with first episode schizophrenia, they would, it's sort of 23% among that group. It's probably higher among people who've had multiple episodes. In the United States, like we have about just under 5% of people with schizophrenia on clozapine. So that then puts the clozapine underutilization gap at, next bullet, 18%. Okay, so we have a lot of work to do. And when I talk to other prescribers, really the work is who are the people that might benefit from clozapine and how do we start new folks on clozapine? That's the only way that we're going to help to close this gap. Okay, next slide. So there's, I think an increasing amount of data around the importance of starting clozapine early. And there was a study from Japan that showed that after treatment resistance, so-called treatment resistance was recognized, when the delay was less than 2.8 years, the response rate for clozapine was 82%. When the delay was longer than 2.8 years, the response rate significantly decreased to about 31%. Now, even if someone has tried, multiple agents, there's been a long delay, it's still definitely worth trying clozapine. And there's data to support this among older adults who have had long periods of, treatment resistance without clozapine. But I show this to show the importance of early clozapine initiation. All right, next slide. So there was a study that was published earlier this year in the Lancet Psychiatry that really and this in addition to other studies have challenged our thought about clozapine as sort of a third line treatment. And in this study, they looked at different strategies for how to how to proceed with an antipsychotic medication after somebody had had a relapse. So like one thing they looked at was, how do people do if they have a relapse and then the same antipsychotic is continued? How do people do if they switch to a different antipsychotic medication? How do people do, this is a first episode, how do they do if they have um, a relapse and then they switch it to clozapine? So, I think what they found was switching to clozapine after the first relapse was linked to a significantly lower risk of a second relapse compared to all the other strategies. And there's also, other data that might support this too. So I think this is sort of suggesting that, again, it's important to think about clozapine early. Next slide. Okay, so, clozapine is underused for people who have, lack of responsiveness to other antipsychotic medications, but it's even more underutilized for the risk of suicide. And the lifetime risk of suicide for people with schizophrenia is around 5%. Study after study, randomized controlled trials, like big naturalistic naturalistic studies, all show that clozapine likely has is associated with decreased mortality, not increased mortality, and less suicidal behavior. And in a large study looking at Swedish and Finnish data, they found that clozapine was the only medicine that was associated with decreased of suicide. And then also people who were taking benzodiazepines and Z drugs like zolpidem actually had an increased risk of mortality. So it's shown again and again and again. And it's often, baffling after someone, might have a relapse or they might have a suicide attempt. The clozapine's not considered after that. It's a really important time to start thinking about it. All right, Next slide. All right, so I'm going to talk a little bit about clozapine side effects. So we did a study one time in Atlanta looking at people who had taken clozapine and what did they say the most common side effects were. And really like sialorrhea or drooling was the most common, then followed by sedation, weight gain, constipation, dizziness with standing. You know, what you don't see on here is neutropenia, severe neutropenia. It's sort of right down at the very bottom. It's at the end there. But really, I think in the clozapine world, we spend a lot of time talking about the risk of neutropenia, um, which can be a serious problem and can lead to you know uh, bad consequences if not monitored and if not caught early. So I don't mean to minimize the problem, but it's actually a fairly uncommon and rare problem. All right, next slide. So I do want to talk about neutropenia because it is the monitoring for clozapine and the documentation of the monitoring with the clozapine REM system that really causes a lot of the complexity that I think really drives clozapine's use down. There's a lot of factors that drive clozapine's use down, and this sort of weekly monitoring in the beginning is one of the big factors. So if you look at sort of the data for clozapine and neutropenia, neutropenia is an absolute neutrophil count of less than 1.5, and it happens in about 4% of people who take clozapine. Severe neutropenia, formerly called agranulocytosis, happens in less than 1%. And then death due to neutropenia is rare, 1 in 7,700, from a meta-analysis from Dan Siskin and colleagues in Australia. The peak incidence occurs early on, which is why we do weekly monitoring. And then 89% of cases developed in 1 year. Okay, next slide. So when we do, when we do clozapine, when we start new folks on clozapine, this is sort of some of the monitoring that we do. And, in the red is sort of which week number. And then we have neutropenia, vital signs, screening for myocarditis and interstitial nephritis. For neutropenia, it's weekly for the first 6 months. Then it goes to every other week for months 6 to 12. Then it's ANC every 4 weeks, monthly, indefinitely. And I think the indefinitely part is where a lot of uh, effort these days is on trying to see if it could be adjusted. We like to monitor also for interstitial nephritis, which kind of could occur early on in a clozapine titration by getting, a measure of kidney function weekly until week 8. And then now a lot of people use myocarditis screening protocols where weekly troponin and CRP are done until week 8. Okay, next slide. Okay, so I wanted to show you this because of the, you know, and if you or a loved one is on clozapine now in the audience, um, I'm sure the complexity of how actually to obtain clozapine resonates with you. We made this figure, and we made this figure sort of wanting to highlight the complexity and like there's a lot of arrows going to a lot of different places, which I think just shows the complexity of the system that's required, and much of it runs through the clozapine REMS. So there's an interaction with the pharmacy, with the patient, with the prescriber, with the lab, and then it's the clozapine REM system that really verifies the documentation of the absolute neutrophil count. And also clozapine REMS, there's a component of it which verifies that the prescriber has certified and gotten some training in clozapine, and there's a stopgap at the pharmacy which verifies that. So yeah, you can see sort of the complexity here. Credit goes to my colleague Aparna Das for making this. Next slide. So many of you have probably been following the FDA advisory, the FDA advisory committee, and the recent, decision in November 2024 to making some changes, and the American Psychiatric Association, in conjunction with SMI Advisor, presented some of these data to the FDA. And we did a 20-question survey to number of prescribers, and over half of the group had trouble getting a clozapine prescription due to the REMS. About 30% noticed that there was a treatment interruption of clozapine in at least one patient. And we looked at the consequences of the missed doses due to issues with the REM specifically. And those sort of consequences involved worsening of symptoms, hospitalization, sometimes clozapine just being discontinued altogether, and people were started on other antipsychotics that really didn't work. Even if clozapine REMS went away, 96% would continue to monitor for the package insert for 6 months. And then many people felt like the barriers outweighed the risks. And some of you might have seen a new study that was, a study of some older data that was just published last week about clozapine REMS and prescriber perspectives on clozapine REMS, suggesting that some people felt like the REM system was working pretty well. But I think what was also interesting in that study was that many of the prescribers surveyed there said that missed doses were a frequent problem for their patients, which can be catastrophic. All right, next slide. Yeah, so the FDA advisory committee is just an FDA, it's just an advisory committee to the FDA, and the FDA can decide what they want to do. So there were two votes that were on the table on November 19th, and the votes were to one of the questions was, should prescribers be required to report documentation of the monitoring in the REMS? And then the other one was, should there be mandatory education through the REMS that's then verified by the pharmacy? And then the advisory committee voted 14-1 to no on both of those votes. So when people talk about clozapine REMS, it's important to differentiate this idea of monitoring the absolute neutrophil count, as per the package insert, versus documentation of the monitoring in a central system that the pharmacy then verifies. That's one of the things that the REMS does. Okay, so monitoring itself versus verification of the monitoring. And I think many people would say that monitoring is probably important, especially during early periods. Okay, next slide. So I wonder this a lot, what might life be like without the REM system? And I think that the REM system is, a well-intentioned system, no question. And I think it's trying to make clozapine use safe. I think the problem is that there's often a lot of moving parts, which can make it difficult to really make sure that the system works 100% of the time. The system has to work 100% of the time in order for people to get their medication. Every month, every week, it can be a struggle. It can be stressful, just to make sure that the medication is dispensed without issue. So I think that if the FDA it decides to implement the recommendations of the advisory committee, it would make it a lot easier for people who currently take clozapine to kind of on a daily, on a monthly basis or weekly basis, get their clozapine. But I do think that there are opportunities for confusion. Like some systems might say, oh well, maybe you need to access the absolute neutrophil count. There might be some off-label monitoring. Like some people, maybe it's just a non-starter completely to even get the blood work on a weekly basis. But I think that the REMS is only one of the many, many barriers that needs to be addressed. And just if the REMS goes away, it's not like I don't think clozapine use is going to triple in the United States. I think it's much more like this is one of the 20 barriers that we really need to figure out how to address. And like education and talks like this, and getting the word out and talking to your networks, um, people advocating to be starting on clozapine, making clozapine part of the residency curriculum for psychiatrists. All of this stuff is really going to be what is required. So this is, the this is a broad, I think, issue that needs to be addressed in many ways. Okay, next slide. So, I want to talk a little bit about the muscarinics because there's, you know, because I think it's pretty exciting. Next slide. And in September 2024, and this is interesting, 35 years after clozapine was FDA approved to the day, a new drug was approved, Cobenfy, and it works through a different mechanism besides just blocking dopamine receptors. And there's a lot of questions about where does this really fit into the armamentarium of medication for people. All right, next slide. So many of you, I'm sure are aware that these medications are what we call muscarinic cholinergic receptor agonists. So something like Benadryl is a muscarinic cholinergic receptor antagonist. So this is working in sort of the opposite way that sort of things like Benadryl or Cogentin, benztropine are working. These drugs have a functional selectivity. They actually bind to all 5 different types of muscarinic receptors in the brain, but they have a selectivity for M1 and M4 in particular, which is important. They were initially studied to treat cognitive symptoms of Alzheimer's disease, but people noticed in the studies that those who had delusions and psychosis, they actually tended to get better when they were taking xanomeline. And there was a study that was done for people with schizophrenia using xanomeline, a small sort of study with 20 people that showed that xanomeline was effective, but unfortunately it had pretty significant cholinergic side effects, as you would expect, and high rates of nausea, vomiting, diarrhea, um, sweating, and hypersalivation. It really by itself wasn't going to work. Next. But it sort of begs the question, like, well, why would xanomeline work in the brain anyway? Like, why would a muscarinic agonist work, given that the fundamental problem for positive symptoms is likely related to dysregulation in dopamine? And I think that, over the last 15 years, 10 years, we're sort of increasingly understanding that the problem, in sort of in positive symptoms in particular in the brain has to do with presynaptic dopamine, increased presynaptic dopamine in the associative striatum in particular. So this one particular brain area has a lot to do with positive symptoms, delusions and hallucinations. Negative symptoms are probably the mechanism for negative symptoms is more complex. It probably involves different neurotransmitter systems. It's you know the cognitive symptoms also probably also. So this is sort of a problem where it's a presynaptic problem. And before xanomeline, everybody was just getting antipsychotic medications that block dopamine on the postsynaptic side and also on presynaptic autoreceptors. So you just and in all parts of the brain. So you're basically giving people dopamine blockade in areas of the brain that might help with psychosis some, but are also responsible for other side effects, like we talked about, like the drug-induced movement disorder side effects, increased prolactin, because dopamine is being blocked everywhere. So the exciting thing about xanomeline in particular is that it is really working in a pretty specific area of the brain, and it's sparing motor areas of the brain. So it's not causing the drug-induced movement disorder side effects. And there's several ideas about how um, xanomeline affects dopamine release, but I think that one way to think about it is there's sort of a pathway in the brain that helps to that sort of is it's a cholinergic pathway in the brain that then kind of innervates an area in the brain called the ventral tegmental area. And then this, if you sort of give a muscarinic agonist, you're reducing presynaptic dopamine in the areas of the brain that likely cause psychosis. So it's probably this idea that it's doing some fine tuning of the dopamine release, and that's one of the things that results in decreased psychosis, at least theoretically. But there's also other ideas about it. All right, next slide. So they looked at a lot of different compounds because xanomeline itself was promising, but the tolerability wasn't good. So they thought, why not combine another medication? And the one that they selected was called trospium chloride. And this is it's a medication that's been used for urinary, and it's used for been used for urinary incontinence, and it's an anticholinergic medication. The interesting thing is it doesn't cross the blood-brain barrier, so it's not affecting the brain. Like anticholinergic medications affect the brain, they affect cognition. We try to do everything we can to get people off of anticholinergic medications. This one, though, doesn't cross the blood-brain barrier, and essentially it cancels out the peripheral effects of the xanomeline. So it really is, in clinical trials, been shown to reduce the sort of diarrhea and the nausea and vomiting. And then, the side effect picture kind of looks like a mild anticholinergic drug, and the combined product is called Cobenfy. Next. So, I think that the phase 3 studies got a lot of people's attention because the effect size was pretty high. It's 0.6. And other antipsychotic medications, you typically might see like a 0.5 or 0.4. So it's impressive in phase 3. Some of the side effects: nausea, dyspepsia, vomiting, constipation. So some procholinergic and some anticholinergic side effects. But interestingly and importantly, we didn't see those motor side effects, and it really wasn't associated with weight gain, which is a really a big deal. All right, next slide. Okay. Just a couple of practical things about Cobenfy. It's given twice a day, so it's also titrated slowly. So there's sort of a process, and then the package insert now it talks about 50-20 for at least twice a day for at least 2 days, 120 for twice a day for at least 5 days, then 125-30 twice a day. So the convention is 50 milligrams of xanomeline, 20 milligrams of trospium chloride. And I think that most people would say, like, if you can increase it slowly, it's probably better tolerated. At least in my experience, it has been. It's not recommended for people with severe or moderate liver disease, and it's not recommended if the kidney function is impaired. All right, next slide. There's a lot that is known and not known about the muscarinics. So this drug, Cobenfy, is only one of the many muscarinics that we expect to. Well, that's sort of currently in clinical trials, and there may be more and more, sort of muscarinic drugs that may come to the market, and it's going to be interesting to see where this all settles out. One thing that is known is that if somebody is taking an anticholinergic medication like Benadryl or Cogentin, if you take it with Cobenfy, that it's going to cancel the mechanism out. So, like, you can't use an anticholinergic and something that does cross the and something that like xanomeline together. There's no pregnancy or lactation data. There's still, a lot of questions about the longer term studies. Right now, what's been published has been these sort of 5-week acute exacerbation, sort of inpatient type studies, and the long term data hasn't been published yet, but it has been presented at conferences It just hasn't come out in peer-reviewed journals yet. And the long-term data kind of suggests that, um, that it's not associated with drug-induced movement disorder side effects like Parkinsonism, and it's relatively, um, and people don't tend to gain weight on this. Okay. The other one that's really an important question right now, and I think people are gaining experience with this, but there's a study going on called the ARISE trial, which is looking at Cobenfy, xanomeline, trospium with other antipsychotic medications. Right now, it's just approved for monotherapy, but it's going to be, you know, and hopefully sometime this year we may see some results that tell us how it does with other antipsychotic medications. May it play better with some antipsychotic drug-induced sort of the dopamine receptor blocking agents than others. And I think that there are other questions too about like what is the role of this medication for people with bipolar disorder, catatonia, um, schizoaffective disorder, all kinds of questions. I think I saw this question in the chat about like, does this new drug work for people with so-called treatment resistance? And will it be used instead of clozapine? Will it be used with clozapine? And I think it does. And I know that people are very interested in using sort of clozapine and Cobenfy together, but I do have some concerns that, from a mechanistic standpoint, can't really see how it would work. Um, Norclozapine has some properties that are sort of like uh, xanomeline, so there's some mechanistic overlap, and also, the mechanism of positive symptoms for people with TRS may be more related to a different neurotransmitter called glutamate instead of primarily a dopamine problem. I know that people will try it. I'm really curious to see what ends up happening. I think it speaks to sometimes the lack of options that we have in addition to clozapine. Like if somebody has partial response to clozapine and some symptoms, like the options that we have right now, there's a lot of things have been tried, and some of them work okay, but there's not a lot of really great options. So I know that people are trying it from a place of, trying to find something. Um, yeah, I think yeah, then there's like a whole another conversation about like, what about people who are already on clozapine, and might they want to even try Cobenfy? Um, you know, yeah, it's still, we don't have any data on that. Um, and I also would say that it's really, really important that if the combination is tried, to make sure that people are continuing to have bowel movements and they don't develop, sort of serious GI slowing. I really worry about that, but with the sort of trospium chloride on board and clozapine, which can be highly constipating. So you know, some potential safety concerns with the combination. All right, next slide. So it leads us, I think, to some questions like, where does this medication fit into the treatment algorithm? Like, is Cobenfy going to emerge as something that we would want to try in the first episode, before anybody ever gets these dopamine receptor blocking agents to see if it works? But sometimes the problem is that insurance companies are still trying to, figure out where Cobenfy is going to live, and sometimes they require step failures, like you have to try one or two antipsychotics before you could even go on Cobenfy. And what I worry about is, um, you know, with this option, is it gonna slow down the use of clozapine? Like, is it going to, you know, s- is it going to say instead of two antipsychotic failures, maybe somebody's going to try two antipsychotic failures and then Cobenfy and then clozapine, and might that reduce the response rate for clozapine because of the delay? And we talked a little bit about the clozapine augmentation with Cobenfy question. This is one of those things like where you gotta love AI, it's like it comes up with these little icons and why it came up with a dog made out of the balloon dog for clozapine augmentation with Cobenfy. Does this make sense? I don't know. I don't know what it was thinking. I couldn't change it. So we're sort of left with that. The other two were fine, but the dog, I still don't understand. Okay. Next slide. And I wanted to leave you all with some, new resources as well, that might be helpful. So I was involved with a project called SMI Advisor that was administered by the American Psychiatric Association, and it was, funded by the Substance Abuse and Mental Health Services Administration. And it was a 6-year grant. We did a lot of, I thought, really great work on clozapine. And in the summer, we had an individuals and families page for resources, and we had videos of people who did well on clozapine. To go to the next slide. So there's a new resource that was launched in January called the SMI TTAC, which is kind of like an SMI Advisor 2.0. And this is operated by the National Council for Mental Wellbeing, and it's done in partnership with the American Psychiatric Association and other partners. It's funded by SAMHSA, the Substance Abuse and Mental Health Services Administration. And if you check this out, there'll be resources on SMI and clozapine. And next slide. Here's a little bit about some of the goals. It's really to kind of focus on evidence-based resources. And then we offer technical assistance and consultations to stakeholders. And go to the next slide for a second. And if you're a clinician, you can actually submit a request for personalized individual technical assistance, which is sort of like a consult, kind of like we had in the consult service for SMI Advisor. So you can go to this website and submit a question and get an evidence-based response in, like 3 business days. And it's free, and, it's sort of it's like a service to consider taking advantage of. In my role with SMI Advisor, I get a lot of questions about clozapine from other clinicians, and sometimes people with lived experience, or sometimes family members. All right, next slide. Yeah, so in conclusion, schizophrenia is a highly treatable condition. We've come to expect recovery. It can be treated with combinations of psychosocial and medication approaches. There's some new treatments on the block, and we've got to kind of see where they're going to fit in to the treatment algorithm. Clozapine is an incredibly important compound that can really help people get their lies back and can make really impressive transformations. And then to really get the best response, offering early is helpful. And yeah, so in conclusion, I'm just really grateful to be here. There's been a lot of great questions that are coming in through the chat that I haven't been able to address, but we will have some time for Q&A, and maybe we can talk about some of those questions then. Thanks again to everyone.
Thank you so much, Dr. Cotes. Very happy to have you tonight. It was an excellent lecture. Oh boy, we do have a lot of questions in the chat. Let's see how many we have time for, maybe 10 minutes. Dr. Cotes, is there a question you prefer to answer first?
All right. So we've got a lot of great questions. Let's sort of we can do some speed rounds. All right. This is a question from Heather. Do you have any suggestions for the morning fatigue that clozapine causes? Okay. Well, first thing is try to dose all the clozapine at bedtime. That's very important. 75% of clozapine in North America is given at bedtime. It's incredibly sedating in the morning. The package insert says give it twice a day, but you really don't have to. So bedtime is important. Also, trying to take a little bit earlier in the evening is helpful. Also, reducing other medicines that can cause fatigue or sedation, making sure it's not another issue like depression. Things like people have studied, compounds like modafinil, which probably don't tend to make much of a difference. It's a very difficult side effect to treat sometimes. Sometimes physical activity is helpful, sort of spending this concept of spending energy to kind of get energy. Getting people on a routine can be helpful. So it's tough. All right, next. If you slowly wean off clozapine and notice symptoms start again, can you go back on it? Yes. It's important to titrate it gradually instead of just starting at the previous dose. There's some new guidance in the package insert that talks about retitration. Next question, 2 questions. With LAIs, can you take additional oral dose if experiencing episodes in between injections? Sometimes what happens is, with the long-acting injectable that lasts like a month, sometimes during the 3rd week, sometimes people can have what's called breakthrough symptoms, and in those cases, additional oral medication can be used to help. You want to look at other causes of that. Sometimes if the dose of the LAI is not optimized, you can go up on the dose a little bit and see if you can reduce some of those types of breakthrough symptoms. Next question, are there other antipsychotic medications that also cause neutropenia? The answer is yes, but clozapine does so at a higher rate, slightly. All antipsychotic medications can cause neutropenia, but clozapine is, more likely to cause neutropenia than the other medications.
Does anybody
Next question.
anybody in the audience want to actually speak out? You'd be welcome to do so at this time. Maureen Henry, go ahead. To unmute yourself there.
My son is on Cobenfy. He is still having problems with anhedonia and lack of interest in anything. Can you add an SSRI or mood stabilizer?
Yeah, anhedonia is can be a really tricky thing to treat. And mood stabilizers or SSRIs can be added to antipsychotic medications. It's important to watch for drug-drug interactions. There's no significant drug-drug interactions that jump out for me with most SSRIs and Cobenfy. I think that overall, like SSRIs have maybe some small levels of effectiveness to help with anhedonia, particularly the activating SSRIs. But also like really thinking about what other non-medication sort of factors are available. Like, are there things like cognitive remediation, sort of where you live, or cognitive enhancement therapies, so those types of options. So optimizing both medication and non-medication ones. But like anhedonia itself, important to maybe differentiate from depression too, because if it's sort of anhedonia from depression, treating the underlying depression can help.
Anybody else have a raised hand? If not, we'll go back to the chat. Go ahead, Dr. Cotes.
Yeah, sorry, I went into sort of the rapid fire questions thing. Much better to chat, among us. Thanks, Bethany, for suggesting that. Sorry about that.
It's okay.
I
Anybody
just
else
wanna
want anybody else want to speak up? We have Claire. You'll have to unmute yourself, Claire.
Okay. Working off talking about the anhedonia, we're experiencing great results on the clozapine for our son, but the avolition, the lack of initiative, is still a really big problem. And I think it leads to maybe a little depression, like where am I going? Why aren't I doing anything? Things like that. You have any thoughts on that?
Yeah, avolition can be a really difficult symptom to treat, and I think part of the problem is that the treatment options that we have for avolition and anhedonia really aren't that great right now. There's some new things that are in development, thinking about using compounds that affect receptors that might be more helpful with that, but really, like, there's not a lot of great options right now. I kind of go often back to some of the psychosocial interventions to see if that might help, really trying to get on a schedule, getting to work. But it's a really, really tough symptom. And I think that a lot of times what I see is, it sounds like, Claire, you know what it is, but sometimes people don't know what it is, and they think it's some sort of thing. They think it's something that the person's just not doing. Like there's something about their drive. It's something, that's not actually caused by the illness. It's like a person. It's related to them, and it's really not. And I think that that's like the first thing is understanding that it can be part of the illness. In fact, as we talked about before, sometimes it's one of the most impairing parts of the illness, really.
Um, someone just had their hand up. I don't see them anymore. Anybody else?
Oh, sorry, I put my hand down.
Ambulance, go ahead. You can
Yeah.
start video too if you want to.
Oh, sorry. I don't think my camera's working right now, but that's okay.
Okay, go ahead.
I'm a clinician and I work at a therapeutic farm in Middlefield, Ohio, where we specialize in severe mental health. Have a lot of patients with schizophrenia and schizoaffective who are treatment refractory on clozapine, and still only showing, so limited effects. I was just wondering if you had any insights on those who continue to present treatment refractory even with the clozapine. And we have two individuals who are currently trialing clozapine with Cobenfy.
Yeah, I'm curious, how's that going?
Very mild improvements, nothing too significant, mild, but we're still on the early titration.
Yeah. Well, thanks for that question. That question is really what drove us to start the P-Star Clinic back in 2011. Was, clozapine works great, clozapine works wonders, but still a significant number of people have persistent positive symptoms and negative symptoms and cognitive symptoms even while they're on it. And it takes so much effort oftentimes to kind of get to that point where someone is open to clozapine, get clozapine on board, and it's these persistent symptoms that I think are really, really tough. So, it's a really tricky problem. I think that there's sort of different ways you can kind of think about it. The best, probably the best evidence that we have is to consider ECT with clozapine for people who have persistent positive symptoms. Also, if you look at expert guidance, expert consensus guidance would say that, maybe combining medications like aripiprazole sometimes can help partial agonists. And there may be some role for using aripiprazole to help reduce cardiometabolic side effects of clozapine and possibly even reduce weight gain type side effects. All of that and even sedation, but all are very, very limited evidence with that. But I think that aripiprazole is really one of the more common strategies. I think I saw Dr. Nasrallah, and pimavanserin has been something that people have looked at. There's a number of strategies I would sort of put into ECT, antipsychotics, pharmacologic non-antipsychotics, and then psychosocial interventions. And like the first thing that we do is think about the psychosocial interventions. Again, it's like, okay, persistent positive symptoms, CBT for psychosis, really like what are the other social interventions that might help? And then we'll kind of go back and look at, considering ECT, considering different antipsychotics like a partial agonist like aripiprazole, and then considering sort of antipsychotic pharmacologic options. But there, like in my experience, there's no one right answer for those, and sometimes it takes a bit of trial and error to really find something that helps. Yeah, the persistent symptoms can really be quite tricky, and you need different approaches for probably positive, negative, and cognitive symptoms.
Thank you.
Thank you, Dr. Cotes. It's 7:10. I think we should let you go. If somebody has an urgent question, email me. I'll have either Dr. Cotes or another doctor respond. Thank you for joining us. Thank you again, Dr. Cotes. We really appreciate you.
Thank you.
Thank you, Bethany.